Welcome, Doc.
Good evening, everyone, and a very warm welcome to all the esteemed doctors, teachers, researchers, students, and all the homeopathic enthusiasts joining us from different parts of the world. It gives me immense pleasure to welcome you to all the 2171st day of the uninterrupted daily webinar of the International Forum for Promoting Homeopathy, IFPH. I am delighted to be your moderator for today's scientific session. IFPH is an international homeopathic humanitarian organization working with the vision of bringing together homeopaths and homeopathic movements across the globe and promoting homeopathy through the knowledge, education, and scientific exchange. We are truly grateful to IFPH for providing this wonderful platform where doctors, scholars, academicians, and students can come together and share their knowledge and clinical experience. And now it is my privilege to introduce our distinguished speaker for the today. Our guest speaker is Dr. APEXA RIBADIYA, an MD homeopathy scholar from a Department of Organon of Medicine and Homeopathic Philosophy from Rajkot Homeopathic Medical College, Parol University, Gujarat. Dr. APEXA is going to enlighten us today on a very interesting and throughout provoking topic, acute urticaria, miasmatic thread of latent susceptibility. The topic beautifully connects the acute clinical presentation of urticaria with the deeper concept of susceptibility and miasmatic understanding in homeopathy. I am sure today's presentation will provide us with valuable academic insights and stimulate meaningful discussion among all the participants. So, without taking much time, I warmly invite Dr. Apeksha Ribadia to take over the session and share her valuable presentation with us. Dr. Apeksha, are you there?
Yes, yes,
Am I audible to everyone?
yes. You can
Yes, yes.
adjust your camera a little more.
Okay.
For
Is it fine?
now it's fine.
Good evening, delegates, colleagues, esteemed members of the International Forum of Promoting Homeopathy. I am extremely heartily honored to stand virtually in front of everyone, which is the team which is dedicated to the advancing classical philosophy through the lens of the modern medicine. Wherever the people are tuning from the basic clinics or the home setups or the academic institutions or all over the globe, I heartily welcome everyone and also thank you for joining the session for today. Now I'm starting my screen share. Hope it is visible to everyone. Is it visible?
Yes, it's visible.
Like I would start with, like in daily practice, we have the acute flare-up of the acute urticaria, which is merely defined as the uh, histaminic store or the storm, which is basically triggered by the environmental factors or the risk factors or the stressors, right? But when we look closer through the lens of the classical philosophy and the modern medicine also, the immunophysiology, the basic question arises is the whether it is why the same environmental factor or the element from factor, but the two people are responding in different way, right? Why is it so? The question arises in as a beginner like me, a PG student, or the new fresher, neophyte. They have these questions that why it is so. Okay, why two people are reacting in a different and that too one in an explosive way and one is not remain unaffected, right? So we'll explore today's session uh, according to this topic only, that is the acute urticaria, miasmatic thread of latent susceptibility. And we'll also unlock and explore that hives or the worlds which we describe are not just a superficial event, but it is also a dynamic derangement of the internal vital force, right? So moving forward, we'll see what are the objectives of today's talk we have. there are the 4 basic objectives which will have to fulfill at the end of the session, which I aim to give to the audience today. That is, the first is the deconstruction of the acute illusion. By this, what I mean is that we have to look beyond the hives or the words appearing as the clinical manifestation. The second is the delineate the miasmatic expression. What does this suggest? We have to understand the miasmatic expression, which the understanding of the acute manifestation of the disease. And here basically we are speaking about the acute urticaria. The third point is the bridge between the modern immunopathology with the Hahnemannian principle. All the principles or the philosophies, the works we have of the stalwarts will correlate with the modern immunopathology. That is the basic pathophysiology which we study in the clinical book, the allied side. Then the fourth and the most important, maybe what this IFPH is doing right now is giving importance to the clinical experiences, right? Clinical cases we have to evidence based what is the current running scenario is all these 3 points how will correlate and help in the clinical prescribing strategy. That when we are going in a real case like scenario, how will all these pointers, all this will help in the prescription strategies or the prescription method, right? So now we look at the map, how we are going to travel along with this session of whole session, what points we are going to cover. First, we start with the introduction. That is introduction by what is acute urticaria, what is the chronological physiological factors, what is the basic physiology behind the acute urticaria. Then we'll move on to the philosophical point of view, that is what all stalwarts are saying or what they have said about the acute manifestation or the local manifestation, local affections, what they mean. And then we'll, of course, as homeopaths, everyone has to dig down that what is the miasm behind it, whether it is the acute flare-up, acute disease, chronic disease, whatever the disease may be. But we have to analyze that what is the miasm behind it. So definitely we'll also go through the miasmatic spectrum as well. Then after all this, the theoretical concept, then we'll go to the clinical aspect, that what pathway should be followed or can be followed for the better result or the better way from which we can have less changes or the errors we make in the practice. So what a pathway should be followed, and at the end it will be reflected or understood with the help of a case profile, a clinical case scenario, right? So we'll move forward with the starting. What is basically acute urticaria? How it is defined, and basically what we understand by urticaria. So it is defined at the worst or angioedema, which lasts for less than 6 weeks of duration, and usually it is self-limiting disease. It does not require any medications or any external application generally, and it resolves within the 24 hours of duration and leaves no residual type or skin type after the deappearance. And if we talk about the epidemiological section, 20% of the people are almost affected once in their lifetime with this acute episodes of urticaria. And mostly the episodes or this acute or chronic, both either with urticaria, they are idiopathic. What does it mean? It suggests that undefined cause has been identified. There is no definite cause of this urticaria, how it is occurring most of the case. And if once this urticaria has started, then it resolves mostly spontaneously, and the days week it takes to cover. Moving forward, now we look at the basic etiological factors. What are the basic factors which leads to this disease or this condition? Now we start from the upper left corner, that is from the circle of the upper left corner, that is the trigger. So, the infectious condition. Now, infectious, how, by giving an example, what does infections mean? It can be viral, bacterial, or fungal infection. Like viral can be hepatitis viral, Epstein-Barr virus, which can cause conditions like upper respiratory tract infection, hepatitis-like condition. And if we go with the bacterial infection, example can be taken of streptococcal infection or the staphylococcal infection, which leads to upper urinary tract infection or pharyngitis, laryngitis type of condition. And along with that, other systemic involvement could be in the form of acute urticaria presentation too. So it can be considered as one of the etiological factors. Now moving forward, the second factor is the IgA mediated one, which as the point like food like nuts, food, fermented food, which can also lead to urticaria presenting. Then the bee stings or any insect bite can also lead to such an flare up or a skin condition. And third can be environmental factors like pollen grains or would be like any dust particles. Who the people are very sensitive to dust and polar dust specifically nowadays. So that can be also one of the factor causing this urticaria. Then the third would be drugs induced, like penicillin nowadays. It is not been taken, but once it was also a factor. Then azithromycin or the current running scenario is the DOTS treatment of the TB patients who are following that 6 months or 9 months regimen. They have been shown in some of the scenarios or some of the articles that the people having that medicine, they are having acute episodes of urticaria, or some in some patients they have also remained after the treatment is over also. So they can be considered as one of the etiological factors. Then the fourth is the physical trigger, in which we can have this extreme point of temperature, that is high chilliness, or the high temperature of the heat waves or heat strokes. We can also lead to urticaria. Pressured clothes or pressure can also lead to such hives or whorls formation. Then even exhaustive exercise, extra exercises can also lead to urticaria. Now, yes, of course, 30 to 50% of acute cases, they have no identified causes, so they are named as idiopathic causes, as we discussed in the earlier slide. So these were the five main etiological factors of acute urticaria, that is the infection, IgE-mediated, drug-induced, physical triggers, and the idiopathic one. Now we'll move forward with the basic mechanism of the pathophysiology of the acute urticaria. Now with this slide, let us divide this into three parts. First is the pathway, second is the degranulation portion, and the third is the response. Now, if we understand these pathways is a combination of two things, that is the immunological and non-immunological pathway, right? So pathway, in immunology, first we'll look at the immunological pathway. It has three components: type 1 hypersensitivity reaction, type 3 hypersensitivity reaction, and the viral infection, which is the positive factor here considered. So if we combine these three, they activate the receptor of the FCE receptor, which is the complement activation pathway receptor, and it works through the complex formation and the complementary axis formation. It works in that microbiological level. And now, if we talk about the non-immunological sector, then they block or they inhibit the arachidonic acid pathway modulation. And they can be from the medicine point of view, that opioids, aspirin, vancomycin, NSAIDs, the people who have that continuous use of that or the repetitive use of that can be triggered by this non-immunological pathway. Now comes the second portion. This both immunological and non-immunological pathway combines and lead to mast cell degranulation, which further leads to mediator formation. That is, it releases histamine, protease, cytokines, chemokines, eicosanoids, and some new mediators like heparin, TNF-A, TNF-alpha, TNF-beta. They also releases, and their effect is what we see in the sign and symptom formation. That is the vascular and nerve affection. There's itching, whorls, and some advanced conditions like angioedema or urticarial vasculitis. Even pain is found, biting sensation with the itching. So this was the basic pathophysiology we have in briefly I have tried to make up here. Now, moving forward, after understanding all the etiological factors, pathophysiological factors, now let us look at what are the clinical features of the acute urticaria. Like everyone knows, clinical features are the three main components over here. That is the whorls, erythema, and pruritus. Now, what is whorls? They are the skin lesions which are slightly raised and ill-defined margins, but definite margins. Irregular margins, not maybe circumcised circle or a specific shape would be maintained, but the margins would be defined. Now, the second is the erythema. What do we understand by erythema? Erythema is the redness around the skin lesions. Then the third is the pruritus. Pruritus basically means the itching, right? So itching, and this is the most distressing symptom which patient faces who is suffering from the urticaria. Either way, so whether it is acute or chronic or subacute kind of urticaria, but most prominent and disturbing symptom which hampers his lifestyle is the pruritus, that is itching he's facing. Now the question arises that this disease is basically only focused on the skin, or it is the deep down origin. What is the origin of the disease? Whether the skin is the origin of the disease, or it is just an expression or the manifestation of the internal derangement. Now, to conclude, to wipe out this confusion, in this slide, there are two terminologies given, right? The first is the acute illusion, and the second is the peripheral fallacy. I would like to first start with what does it mean by acute illusion? Can anyone help me, or say what do you get this by hearing this term or reading out this term, acute illusion? Okay. Illusion is the misperception of any of the understanding we have. It is basically misconception which leads to wrong understanding or the wrong conclusions, right? So here, acute illusion here means we are in an illusion where we have that material or the content we have is the confusional, or we are not getting it rightly. So to clear this acute illusion, we have four pointers over here by which we can have that question answered, that whether it is a manifestation or the disease itself is only limited to skin, right? The one of them, the first pointer, is the peripheral fallacy. Now, can anyone guide me or help me to make everyone understand what do you mean by peripheral fallacy? Okay. First, we'll try to understand the terms differently. Fallacy is the error in the reasoning which leads to wrong conclusion. Like the reason we are giving behind, or the process we are understanding, the genesis we are understanding behind the any outcome is the wrong, which is leading to wrong conclusions, right? So here, peripheral fallacy, I mean that when only a hive or a whorl is treated as a single isolated skin error, then it ignores the underlying dynamic tension. Like only the skin portion or local affection is treated, then it is ignoring the underlying dynamic range. Now, let us understand what stalwarts say about this statement or this concept. Now, the first is the master himself, the Samuel Hahnemann, sir. He, in his Organon of Medicine, 189th aphorism, he stated the local application does not exist, persist, or worsen without the participation of person as a whole. I would repeat again that any disease or the manifestation will not exist, persist, or worsen without the participation of whole of the organism, or here we would refer to as a vital force. Without participation of vital force, any manifestation is not possible. And he also continues in the 190th aphorism that for any true local affection, there is a necessity of the derangement of internal vital force alteration. So what does he combinedly say? That first and foremost, there should be combination of everything, and vital force is also needed in the disease formation, or to worsen even vital force is needed. And what he says is derangement is the first and foremost thing required for whatever changes we have in our body. This has Hahnemann sir talked about. Now let us see what other stalwarts say is the integrator, the Roberts, Dr. Roberts. He states in his principle of art and cure that skin is the easiest way body can save the vital organ. Like skin is the least vital organ, and body tries to save the vital organs and throws the symptoms or the derangement to the skin, so the vital organs are saved. So if you are treating the local affection, then maybe you are in the derangement to progress the disease instead of curing the disease. Now let us see what the third person says, that is the critic and the systematizer. He says about the critics what the people that time used to say, that skin lesions are the independent entity and they should be treated independently, like the use of local applications, steroidal antihistamines. But he took it and said this statement as a fundamental error, that if you are considering the skin as an only single entity or a disease, then how can you expect cure out of it? That the fundamental restoration or fundamental cure should be dynamic restoration of the deranged vital force from within. The only removal of the symptom would not help the patient to be cured. Now, this we talked about this first point about the peripheral fallacy under the acute illusion. That is the Hahnemann sir, Robert sir, and the James J.T. Kent sir. Now moving forward to the second point, that is the causa occasionalis, which everyone knows that is exciting cause, which can be dietary changes, antigens, antibody reaction, and NSAIDs, proteins, thermal changes, environmental changes. But they are only the exciting cause. They are not the primary etiology or not the primary factor for the disease to appear. Now let us look at, for this point, what our stalwarts have said in their works. The first is the intellectual polymath, the Hahnemann sir himself. He said, has emphasized on the aphorism number 5 about the emphasizing on the exciting causes, that for any acute manifestation, exciting cause must be looked forward or should be emphasized while taking the totality of symptoms. But rightly, in aphorism number 73, he has also said that exciting causes are only the triggering factors for disease to appear. They are not the main cause of the disease. And they help to awaken the latent miasm within or the dormant miasm within, which reflects in form of manifestation. So what the core we get, or what the conclusion we get is the exciting cause is just a triggering factor which activates or stimulates the latent miasm, but it is not the primary cause of the disease. The second person is the Vicarious himself. He has distinguished or defined point, that is the exciting cause and the predisposing factors. By giving an example of spark and the gunpowder. The gunpowder is that the content used for making bombs or explosive materials in those times. So he has explained that gunpowder is a predisposing factor, or we can say a go down or a go down kind of a thing we have, which needs a spark, or he has said the exciting cause to get triggered or to get exploited. So if you think the vice versa, that for a spark to enlighten or cause an explosion, predisposing or the latent content or the latent miasm is needed. So he said that exciting causes act only as a catalyst, not as a primary cause of the disease. So he has given the causa occasionalis as the trigger, that is the spark, and the pre-existing potential, we can say dormant miasm, latent miasm, or the predisposition as the gunpowder or the basic soil from which the disease may grow. Now the third point is the J.H. Allen sir, who is known as the Hahnemannian purist. He said that any exciting cause or the exciting factor causing disease is the latent sora himself and not the disease. That basically any person predisposition is having a soric soil, and anything triggering that soric soil will cause the latent sora to excite from the dormant stage to the manifestation of the symptom, sign and symptom. So he has named here itself the latent soric soil rather than using other terminology. Now this was the second point, which we has the three stalwarts having here, the Ellen sir, Henneman sir, and the Stewart Claus sir. Under the pointers, second pointer, Causa occasionalis. Now the third thing, what the topic is about, that what is latent susceptibility. Anyone here who can help me or at least give me more knowledge about what is latent susceptibility? As all many of the seniors have joined the session, so they can guide me even more if I'm wrong somewhere. So anyone would like to highlight anything about this? Okay, let us try and understand what is latent susceptibility. It is a dormant stage of a vital force or a vulnerable state of a vital force that is clinically manifests itself when it is triggered by any of the exciting factor which is appropriate to that particular person or that particular vital force. It gives rise to acute or to the chronic stage. It's like basically we try and understand it is a dormant condition which is a vulnerable state. When an clinical manifestation occurs, and it can be either in the form of acute stage or in the chronic stage. Now this concept is given by the many stalwarts by different metaphors used or terminologies used. Let us see what stalwarts have talked about this latent susceptibility. This slide contains three parts. The first is the stalwart column, second is the concept of latent susceptibility, and the third is the key metaphors what they have named or used instead of this term latent susceptibility. Now starting by the first column, that is the Henneman sir. He has given the concept of latent susceptibility saying that it is the underlying miasmatic state which needs the exciting cause to unlock the acute manifestation or explosion or outburst. Like any, like what we have learned in our bachelor's or now we are learning that anything to grow needs a soil. The same minerals, the contents which that particular plant is needed to grow. This similarly helps to understand is with this dyscrasia, underlying miasmatic state, and in combination with that exciting cause leads to development of the disease or the acute exacerbation or the acute manifestation. In key metaphor he has used is this exciting or stimulating the acute explosion is termed as the awakened soil. That this exciting factor, what fertile soil we are having within us, this triggers and leads to disease manifestation or any explosion. Now, the second person is the H.R. Robertson. He says that it is an inherent and acquired soil that distorts or diverts the normal cellular irritability into the abnormal ones, that is the pathological symptoms like structural changes or any destructive changes. And this he has used the key metaphor or the word used, vicarious safety outlet. What does this say? That what we took example of the skin itself, the skin is the less vital organ. So the body to save the internal vital organs, it diverts the symptom or derangement is reflected on the least vital organ, that is the skin. So skin can be in this condition, skin can be said as the vicarious safety outlet. Like the third pioneer is the J.H. Allenser. He said that the latent sora does not allow the disease to come, but it dictates the pathological form, which acute outbreak leads to acute outbreak. But like any disease to occur, there is a need of miasmatic diathesis, which means by which he means that the person should have a tendency to develop certain pathological symptom or have a susceptibility of the body or predisposing factors that that certain symptoms develop. Now the fourth is the J.T. Cancer. He has said that the body or the susceptibility specifically has an internal dynamic vacuum or a void which allows the external causes to come and develop disease and show in the form of manifestation, clinical manifestation. So he has named this dynamic immortal void or resonance as the simple substance affinity, which leads or helps in the development of the disease. And the final, the Stuart Claus, sir, what he has said is about the gunpowder and the spark theory, what we have already discussed, that gunpowder is our soil we have, or the stored material we have, and the exciting cause is the explosive or spark material, the triggering factors which alters the physiological response and manifest in form of expression. So he has gave the metaphor keyword that is the gunpowder versus the spark. So this was about the third point of the latent susceptibility, and we have gone through the five pioneers, what they have said about this, and the metaphors they have used. Now, moving forward, was the fourth point, that is the vicarious safety outlet. Now, what do we mean by vicarious safety outlet? Let us break down the word and understand. Vicarious means the substitute. Like if already the body's vital force is deranged, physiological state is slightly deranged from the homeostasis, but not completely led to a pathological condition. Then what is body trying to do, or how is body trying to help us to not go into the severe pathology? So body tries to go in a safer way, safe road लेने का, they are trying to take a safe drive. So here it means that skin serves as an external envelope projecting systemic turmoil outward to the protect internal organ system. What does it mean? That skin is the less vital organ or less vital functioning thing, on which the internal systemic turmoil, internal whatever derangements are going on in the vital organs, all that are projected on the skin. So body is trying to reflect it on the less important thing and saving and protecting the most important thing within them. So for this, let us see what stalwarts say about this safety outlet. The first is the Samuel Hahnemann, innovator. He says that any external application or any external symptom is forced when or any application is done which tries, it leads to the vital force from moving to less important organ to more important organ, which he has mentioned in 2.0 aphorism, that suppression can cause inward disease reflection, which can be more dangerous and more harmful and even more complicated for the physicians to unreveal too when he is going on with this prescriptions and follow-ups. So Hahnemann has warned about do not suppress the external symptoms and look and prioritize the internal derangement of the vital force. Now the second is the meticulous record keeper. Like everyone knows about the Herring's law of cure, that from within outward is the ideal and fundamental direction of the cure, then the more important organ to less important organ. Now, as the skin is the least vital organ, and the urticarial outburst is an attempt to keep the internal disturbance or the internal disharmony to the periphery itself. So the direction of cure is from the within outward. So we should not suppress the external manifestation to lead into internal disharmony. Then the third is the high potency pioneer, that is the cancer. He has also the similar concept about the what two stalwarts previously said, that skin eruptions cannot be and should not be removed by any topical applications, that is antihistamine, steroid, or any other medications. It can lead to visceral changes and affections, which normally we see is the alteration of the respiratory complaint and the skin complaint. Whenever the skin complaint goes off, respiratory complaint come up, that is the eczema and asthma is the most common example that alternating we have in the alternating symptoms, the alternation of the systemic affection. So that we can understand that suppression can lead to organ conversion, that the skin is maybe going on, but the internal derangement is increasing. Now, to concluding this, I have a video to show.
The skin is a safety valve. Internally, stronger. Disease on the internal organs, lungs, gut, and cramping. It can strike the central nervous system, causing intense or brain fog. Never block with the vital force discharges.
I hope the voice was clear and evident. The words were audible to everyone. Now, as we have the pathology of the modern time pathology also we have discussed, and the stalwart concept has also been gone through. Now we'll compare and look at both the perspective. Here are the two. This slide is divided into two portions. The left is the modern concept, the modern pathophysiology, and the right side is the homeopathic perspective. Now, let us first go through the modern perspective. This has the three key components, that the cellular cascades, which we saw the pathways and microbiological level. Then the second is the vascular dynamics, that whatever the symptoms they are producing. And the third is the therapeutic paradigm, that is the antihistamines or steroidal applications, whatever medication, allied or allopathic people are using. And the right side shows the homeopathic perspective, which we have concluded for all three sides. Is the first is the any outer manifestation or a sign and symptom only will be reflected when there is an internal dynamic disturbance. Without disturbance, there will be no manifestation. Second, wherever or whatever is this acute condition, acute flare-up, or it is a chronic condition, there is a pre-sensitizing component along with the excitatory causes. Like, to be specific, in this acute urticaria, we can say the emotional changes, dietary changes, any food ailment factors, or the environmental triggers, any of the exciting causes, along with the pre-sensitizing soil, can lead to any manifestation. And the third is the therapeutic thing, is the only solution we have is the restoration of the internal derangement what have caused. Without restoration of internal derangement of vital force, no cure can be established. So this was the basic comparison, or we can say the conclusive perspective of the modern and the homeopathic perspective, what till now we have been going through in this session. Moving forward, now the question arises that whether we'll consider acute urticaria under the acute miasm or the chronic miasm. Like, how we'll classify it under what classification will be acute urticaria. Like acute urticaria, as name suggests acute, it doesn't mean it would come under the acute miasm. So let us go to the basics and the definition what Hahnemann sir has given in the Organon of Medicine. So in this slide, we have the basic thing, that is acute miasm and chronic miasm. So acute miasm, as rightly described in the aphorism 73, that is, it's caused by the external specific infection or contagion, what he says, and it follows the fixed natural course, and the termination of this disease or that person would be either death or the recovery, right? And now, if we talk about the chronic miasm, then it is classified, it can be classified as the acute flare-up of the chronic disease, because for the acute flare-up too, there is latent sora has to be awakened. Latent miasm also needs to be excited for the outburst of the skin manifestation. So it can be said or classified under the acute flare-ups of chronic disease. So it can be classified under chronic miasm. Now, to conclusive, here is the one more video. Everyone might find it interesting.
Vicaria is not
I hope it was audible to everyone and clear the words which have been projected in this video. Now, moving forward, of course, the miasmatic spectrum. After understanding all the concepts we have, let us see what the miasm says about, and how we'll understand in perspective of the acute urticaria specifically. Yes. this has the 4 components, this table. The first component shows the components what we are going to compare with, and the rest 3 are the 3 basic miasms, sora, psychotic, and syphilis. Now the first we'll see the sora. Of course, sora is the functional changes, so there will be sudden appearances of the whorls or hives, severe itching would be present, and the pinkish, rosy red appearance would be present, and the sudden appearance of the whorls would be present. And if we talk about the psychotic manifestation, then onset would be slower, and that the whorls or hive will be paler slightly compared to soric manifestation, and would be prominently slightly high raised than the soric manifestation. And now if we talk about the syphilitic manifestation, there can be hemorrhagic purpura could be seen, a bluish, purplish, or a reddish appearance would be appeared, which can be in the advanced stages of the urticarial vasculitis, for example. And if we take of the psychosis, that can be due to angioedema or the giant urticaria or the chronic urticaria side, psychotic manifestation can be said. Now the next is the primary sensation and the thermal modalities to differentiate within the miasm. Then the first is the sora. There will be violent itching, tickling sensation, which would be aggravated by the warmth and ameliorated by the cold application. And if we compare those to psychotic manifestation, then there would be heaviness, bagginess, along with itching. Rather than simple itching, there would be slightly higher inflammation, or what we say edema, a swelling kind of a thing with the itching, and would be definitely aggravated with the cold exposure or cold application. And if we talk about the syphilitic manifestation, then there would be intense itching with the biting pain or burning pain, and it would also lead to bullae formation, which the patient of the burns or first degree, second degree burn patient may have. It can also lead to such type of eruption. Moving forward, if we talk about the tissue outcomes, that what is the outer appearance, soric manifestation would not leave any of the marks behind when the complaint resolves. And if you talk about the psychotic, there would be some of the hypopigmentation, but it would take time to resolve. It will resolve by itself. And the third is the syphilitic changes. There would be hyperpigmentation, ulcerative changes, excoriative changes that can be. And if we talk about the medicines, what can be primarily thought of, that is the soric medicine, that is sulfur, apis, pulsatilla, dulcamara kind of medicines. And if we talk about psychotic miasm, then medorinum, thuja can be thought of. And if we talk about the cyprinum miasm, then lachesis or R-salt can be also thought of in this such a situation. Now, all this was about the theoretical thing, that what are the concepts given, how from where I have taken, what stalwarts have said, what was the modern pathophysiology. Now, let us dive into the clinical scenario or the clinical practical thinking, that what should be the pathway, not should be, but what is the better pathway from which the errors can be reduced systematically. Like the first is the causa occasionalis, that identifies the exciting cause in the particular case. Then the second is the totality formation, which can be by the sensation and the modality. Sensation by meaning, morphology. How is the margin defined? What is the color? What is the size of the whorl? What is the itching sensation? Any other sensation patient is facing or not? Biting or tearing pain, or the location where it is have started. What is the progression? And of course, the modalities ailment from we have talked about, that is causa occasionalis. But along with that, aggravating and ameliorating factors too. That what are leading to this condition, or what are triggering or aggravating this condition. Then the third is the concomitant, that what other system has been involved along with the skin manifestation. And final and foremost is of course the miasmatic diagnosis, which can be done with the fundamental miasm and dominant miasm. And what do we understand by fundamental and dominant miasm? Dominant miasm is the predominant miasm at the present state of the patient when he is presenting with the complaint to the clinic. And fundamental miasm, what he has gained from the parents or family history or the past history, what he has gained. So it is likely to follow, like what if suppose today patient is in storage stage, and his family history and past family history is of a tubercular miasm, of any of the cumulative diseases all family members are pertaining to or having to, then it is a physician's duty to be highly conscious or cautious about the prescription, that whether is it fine, it is fine that today patient is in psoric stage, but it is highly and likely to fall under or progress towards the miasm if it is not taken care of about. So miasm is also necessary and important to evaluate along with the symptom similarity or the totality of symptom matching. So now let us combine both the things, the concepts we have learned till now and the clinical this pathway of what we have done till now with the help of the case scenario. Here is the case of the 15-year-old male entering in the clinic with a complaint of the walls with itching since a month. So he is a student, vegetarian by diet, and like that bossy look and bossy figure, like he is an adult or the 45-year-old person with that power on her face that I am something. That was the look what I myself observed as a physician and the patient, and he was the only 15-year-old boy. So after taking the case and all the details recorded and organized, so we'll start with the chief complaint, which is divided into 4 parts, that is location, sensation, modality, and concomitant. Location is the skin. Since 1 month the patient is having complaint of this thing gradually increasing, that is the ODP. Now the sensation is the walls on the whole body. Itching is severe +3. Red rash is elevated, raising slightly elevation is same. Plaque type is used because the walls are diameter in large diameter, so it cannot be said the eruption. So I have used the word plaque here. And the irregular margins, but definite and well-defined margins. Margins were well-defined, but the irregular, not any particular shape was observed. Now, if we talk about the modalities, ailment from perspiration, hot weather, and food with an artificial color or any preservative or any flavor-induced food. These 3 were the ailment from. But as the gradations are not given because it was not that evident or not, patient was not confirmed about that whether it was coming after that only. But even patient has mentioned himself, so I have mentioned over here too as an ailment from. But the gradation or intensity was not that much observed. Then the aggravating factors were the morning aggravation, anger aggravation, and when the patient is free, when he is not doing any activity, he finds the itching intensity more. Now, what are the ameliorating factors? That the cold water application and the slight rubbing were the ameliorating factors for the complaint. And if we talk about the concomitant, then the irritability was increased according if we correlate with the timeline component. Any other physical changes or physical general changes were not observed. Now moving forward, the physical generals. Now the physical generals, if all the physical generals have been not listed here, only the marked changes or the intensified data has only been mentioned here. That is the desire, sweet, salty, curd and buttermilk, all +3. Aversion, spicy +3. Perspiration, profuse +3. That even half an hour of sleep, if he is lying down and having a nap, that too wets the pillow. So it was so much that profuse perspiration was observed. And sleep occasionally, like 2-3 months or 5-6 months, he would smile or laugh in sleep, but it was not too evident or no any dreams or was what was inquired, but no any dream correlation was found. So only laugh or a smile could be taken, and the thermally was evidently hot, and he had a desire to keep his feet uncovered, while the rest of the body covered. It would be okay, but even in winters, he wants his feet to be uncovered. Now, let us understand the patient as a person going through his life phase. Now, patient was a single child and lives in the joint family. Father, by nature, appears to be angry, irritable, workaholic, and so punctual for his work and meticulous, I would say, that he was so idealistic. Whatever he used to do, everyone has to follow same pattern of work or same quality of work in whole family. Like if he is organizing his own work table also, he is organizing his papers, his books, his files, then he also expects same thing from the patient also, that he has to also be punctual and workaholic and time based. He has to complete all his work on at time. There should be no delay or procrastination followed. And patient who was also attached with the father, and he was used to that work, and he was also possessive about father as well as his belongings too. He would not let any other spoil his work desk or his table or his clothes, any of his belongings. He would not let touch anyone. And if you talk about the mother, she was very optimistic and forthright. He equally attached with mother as well, and he would not sleep without his mother, and he would hold his hand while sleeping, and would praise in front of everyone to everyone about whatever mother does it. Simple, it would be like cooking for him or ironing clothes for him. Whatever work the mother would do, they would appreciate, and he would openly praise her work. Now, if you talk about his reactions, whenever his parents scolded him, he would suppress his anger so intensely that there would be no expression change even on his face, no expression change on the face, and he would like parents would get he is getting angry. But if like in the clinic also, when he appeared in front of me, like he was he like he is sensitive to remarks, and he gets sensitive when he gets scolded in front of the unknown person. Then he was not sitting properly, his sitting posture was not adequate. Then the father advised that you are sitting in a clinic and you are before a physician or a doctor, you should behave properly. Then he suddenly calmed down in such a way that I thought this is a so obedient kid, so calm kid, that he is listening everything of his parents and is not going against. But when the interview of the parents were taken, then the father himself narrated the same incident, and he said that to me, that you might have thought that he has become calmed or he has understood what I said, but deep down he was so angry that he did not express his anger, but he was angry deep down. And when he being scolded wrongly, when he is not at fault, then he would reprimand or would openly comment on front of parents too, that you don't know the matter, you don't, it is not my fault, don't come and argue with me. This was the statement of the mother given when the parents interview was taken. And he was also liable or egoistic, that he would not apologize easily even though he was at fault. And sometimes some anger, like not that anger which he has not suppressed, but in some situations he would cry out when he is angry. So he is also affectionate for the family members and sensitive to the reprimands, and he gets hurts easily. Like about the family members, they have the paternal aunt and uncle living with them and the grandparents living with them. So he's very sensitive about them and very affectionate about them. He treats everyone like his own friend, and shares everything with everyone. Similarly, like he has a bond with his parents, his mother and father. But if we talk about his dominating nature, egoistic nature, even if he is playing or playing in the outskirts with his friends or in the school, when if the games is not games rules are not according to him, then he would not play. He would get angry and he would be stating that way, if you want to play with me, play on my terms and conditions. I would not deny or rely on your condition or what you people are saying. So he is that dominating, what he is saying only that should be followed. Even though at home, even though he's affectionate to his parents, he still finds that whatever I say should be obeyed and should be done that way. And if it's not so, then he would show tantrums, he would show irritability, anger, or in either form. And egoistic was considered because he would not talk to anyone without being pushed. Like even during the interview, when he was brought in front of me for his complaint to what he is, as he was a 15-year-old, so he can speak by himself. So I asked the parents to stay out and asked them to be asked him to be alone there, but the patient he did not speak anything. And once the mother came and told that you are okay, you can be here friendly, you can narrate your complaints, then he was okay to say, but that the tone, that egoistic tone, was very evident. Now, if we talk about the fear of dark and fear cats and lightning, fear of dark plus 3 has been taken because whenever there was a power cut shot at home, he would start screaming and shouting like anything and would ask continuously to parents to call the operator to switch on the lights to resolve the complaints as soon as possible regarding the light cutoff. And fear of cat and lightning was due to his past experiences. When he was small, he was bit by a cat, or that a scratch he had from the cat, so he had developed fear from that. And lightning was too when he was small. He had then of that sense, that noise of lightning, the thunderstorm. So he, from that experience, he had the fear of lightning. Now let us look at the totality of the symptoms. Totality of symptom considered of 19 symptoms, and this was formed on the basis of Kent approach. So the symptoms were taken as like qualified mentals, physical generals, and physical particulars. And it was repertorized in the radar application, and lycopodium 200 was given. Lycopodium was chosen not because of the first remedy appeared in the repertory sheet, but it covered all the mental symptoms, which a physician, as me, I thought that it should be covered, eliminating symptom what we considered. So that
Yes,
symptoms
sir.
and the physical particulars. Yes, sir.
Yes, our time is over. So please just.
Yes, sir. Just one slide. Let's complete. One slide only left. There are the 3 follow-ups and which have been assessed by the urticaria activity score. And their first follow-up was 3 days gap, and the second was the 1 week. At the end, the score was decreased. And these are the before-after photos of the urticaria. And this is the conclusion take-away messages. First is the urticaria flare-up is the peripheral safeguarding of the internal disintegrity. The second point is the causa occasionalis is not just the cause of the disease. We should dive into the internal derangement. And the third is the dynamic resolution, is resolving the internal conflicts or the internal dynamic derangement by restoring the health. And these are the references I have took for making the slide.
Okay.
Thank you, Dr. Apeksha. Now we'll look forward for a question and answer session.
But unfortunately, the time is already over, so we
Yes.
have no time for
Yes, sir.
discussion. We need to conclude. And anyway, congratulations, Dr. Apex. It's really a very good session, and the case is also very excellent. And kindly take care that at least 10 minutes need to be dedicated for discussion. Then only we will be able to have some time for question and answer session.
Yes, sir.
Anyway, it can happen any time. So thank you once again, Dr. Ringle. You can conclude the session.
Yes, sir. As we come towards the conclusion of today's wonderful academic session, I would like to express my sincere gratitude to Dr. Apeksha Ribadiya for taking the time to share her knowledge and insights with us. I would also like to thank our organizers and the entire IFPH team for their continuous efforts in conducting these uninterrupted daily webinars and creating a global platform for learning and promoting homeopathy. A special thanks to all the participants for joining us today and for making this session interactive and meaningful. Before we conclude, I would like to remind everyone that recordings of many previous IFPH webinars are available on the IFPH Homeopathy YouTube channel. I encourage all of you to search for the channel, subscribe it, and continue benefiting from this valuable academic session. Once again, thank you everyone for being a part of today's webinar. Thank you.
Thank you, Dr. Ringle. And tomorrow we will have a session from Dr. Sanket Gupta. He is a homeopathy physician at AKG. Vihar Center, New Delhi, and we'll be talking about homeopathic management of acute respiratory diseases. Thank you all. Good night.